That's great. That's great. So welcome to the SLAM working group. Okay, SLAM working group. I'm going to give you a quick introduction, okay, of this working group. So this working group, you can sort of see that it has very long history. I think for students in the room, the working group was initiated before you were born. I believe that that should be quite correct. Okay, started 1997. Okay, so this is the working group with the longest history. Okay, in this department, and that's a very good reason because you can imagine SLAM represent survival, longitudinal, and is cheating. Okay, and is cheating, but multivariate data. Okay, and this is a sort of a foundation of biostatistics. Okay, so naturally, this working group, is the very first working group in this department. Okay, so the members, we have sort of formal members, informal members. We don't make it so formal, but typically, students, postdoc fellow, faculty, and statistician, from Hawkins or from outside who join the working group. Okay, so typically, I think majority of the participants are from biostatistics department for sure, from School of Public Health, School of Medicine, and also from AMS, from Homewood campus, especially applied math and the statistics department. We have a faculty member, co-leader, also student. Okay. Okay. We also have external members, not like you see, Dr. Sundaram from NIH, NICHD, she's a senior investigator. Later, I'm going to introduce her. She's one of the presenters today, okay? So we have sort of participants from different places, okay? So format of activity, seminar presentation is a typical one, right? But sometimes, actually, a few years ago, we even had short courses. We invite experts in the field, and they came here to give short courses. But short courses means like, for example, give a course twice. Like each time will be like 2 hours, 1 or 90 minutes lecture, and give it a course twice. Okay. Very successful. Okay, so activity of the working group, we also have collaboration among faculty member and also with external members like Raji. We collaborated with her. Actually, Raji supervised one of our PhD students and eventually result in an ASA award paper. We are really proud of it. Award paper. Okay, and the student now is a faculty member at Brown University, assistant professor at Brown University. Okay, so we also mentor students and postdoc, especially if you are interested in the topics we talk about. Okay, because the topics we talk about must be related to SLAM, definitely. So it covers a lot of topics, for clinical trials, time to event outcome, survival outcome is typical, okay? And longitudinal data and multivariate data is very general, almost covers anything. you can imagine, okay? So meeting time, Friday afternoon is the typical meeting time. In the past, we occupied this room, okay, from 12 to 3. But now the department takes it back. Between 12 and 1, it's a public. It's a public time. Everyone can use the room. So now I think we have a sort of we use the room starting 1:15 to 3. Okay, and we provide light lunch like today. If you haven't got the food there, you should go there to get some food. Okay, we have a website. From the website, you can see some of the history and some of the talks we have had, the speakers we have invited, okay? So the focus research area of this working group, any topic related to SLAM. So it's really very broad, okay? It even covers, for example, there's a working group, causal inference working group. From time to time, we also have a causal talks. The reason, because the talks is about using survival data, time to event data, and addressing causal problem, okay? And also, for wearable device data, no, there's a working group called imaging or wearable device. I don't know how they call it.
Smart.
Smart, let's still call it smart.
Yeah.
Okay.
Smart.
Anyway, and we also had a sort of joint seminar with them because even I myself working on wearable device data. And the reason is because, survival analysis techniques, like a point process, recurring event process, it can be applied to wearable device data, okay? So naturally, from time to time, between working groups, we will have joint seminars, okay? So here I just list some topics from recent seminars you can see. Clinical trial, it's definitely a major topic, okay? Machine learning, risk prediction, definitely. Landmark modeling, and prediction of patients with COVID-19, I think you gave the talk. Okay. And primary, secondary prevention strategies for cancer studies. Okay. And we invited statistician from NCI, National Cancer Institute. We invited multiple statistician from NCI in the last 2 years. Hierarchical Bayesian models, okay. Two-phase sampling with longitudinal time to event data. Robust causal analysis and with time to event outcome. So this is a sort of example you see why different working groups could have a joint seminar together. Okay. And restricted mean survival time, that's a popular topic these days, okay? Using maybe, but you could use Bayesian model, you could use frequencies models, okay? So today we have 4 presenters, okay? So me, okay, I'm presenting now. Second presenter, Rajeshwari, Sundaram, you see over there. So Raji, we call her Raji. Okay, Raji is a loyal SLAM group member. She's a senior investigator, okay? Senior investigator is it's a title there. It's kind of like a full professor, at the university. And she's located at the National Institute of Child Health and Human Development, okay? And Dr. Chen Hu is here. Chen Hu is associate professor, okay? As a very active member of the group, okay? His primary appointment is oncology, at the oncology biostatistics, division. I don't know, we call it division or.
Yeah, now we call it division of quantitative science.
Right, but we always call it oncology biostatistics.
Yeah.
There's a group of biostatisticians there. They have a very close relationship with this department. Okay, so Chen Hu will be the third presenter. And today we have a new face. We have Jessie Tong. We are so happy that this year we successfully hired a few assistant professors, and Jessie is one of them. So, it's really wonderful. We were very, very lucky to get Jessie here. So Jessie is assistant professor of this department, just arrived like 2 months ago, right?
I started on August 1st.
Okay. August 1st. Yes, 2 months ago. Okay. So I just have one slide to describe my own research. So my research pretty much, I'm interested in SLAM-related topics, okay? So SLAM-related topics, there could be many, okay? So for example, survival analysis, definitely. I'm interested in survival analysis with a different type of sampling, especially the so-called incident prevalence sampling design. I'm interested in recurrent marker process or recurrent events over time. You can think of multiple infections, or maybe for wearable device data, you can think of activity status over time. Okay. And some SLAM related semi-parametric models and the influence. Okay. And my recent interest such as statistical methods in the presence of competing events, and the terminal events. Okay. So example would be like COVID research. When you look at hospitalized patient data, okay, you could have two different type of competing events. Okay, patient could die in hospital. A patient could be eventually discharged from hospital. Okay, and these two events are mutually exclusive, right? They're competing with each other. So competing events sometimes have sort of similar clinical interpretation. Maybe they're all bad. Sometimes from COVID data set, you can see, sometimes we could have totally different clinical interpretation. Death and being discharged from hospital have totally different clinical interpretation. Okay. Okay. I have some incidental research because I cannot claim I'm an expert. Okay, there's so many experts in this department for working on wearable device data, but I do research on wearable device data. Actually, I just gave a talk at the JSM, a recent JSM Portland. The topic is about wearable device data. Okay. And I also have a new project. My main activity on Alzheimer's disease related project. Okay. For example, I'm working on how to correct so-called survival bias. Okay, in case control studies. Okay, analyzing age and biomarker positivity. Okay, biomarker trajectory prior to the onset of Alzheimer's disease or NCI, mild cognitive impairment. It's a major event for Alzheimer's disease. All right, so that's all I can say about my research. Okay.
Are you able to see my screen?
Yes. Yes.
Yeah, okay, all right. Thanks, Mei-Cheng. It's really wonderful to be part of your group. I was thinking, I started attending from 2013 onwards, if I remember correctly. And the short courses on random forests and others were absolutely amazing. And I'm still using some of them. So I was thinking, how do I go about? I thought, let me talk a little bit about what are the type of research interests that I have and people in NICHD have. Now, all of you know ECHO is one of the biggest, statisticians are getting involved in the ECHO program for funding and so on. So what ECHO says is what I do. Basically, it was designed by our division. So for some reason, my screen is frozen, so I will reshare it. Yeah, okay. I'm not, let me see if I can go to, it's not letting me go to full screen, so I'm not going to, but you are able to see that, right?
Yeah.
So now, yeah, okay. So now, why am I interested in SLAM? On the left-hand side are my research focus. I'm basically I consider myself more as a statistical modeler. But what tools do I use to build my models? They are survival on a multivariate. I'll point out why I am in multivariate world all the time, then joint modeling. And I took the liberty of modifying the M for you, Mei-Cheng, to machine learning. As you know, now all of us are in it. And most of my motivation for my methods work comes from the area written on the right-hand side. And I chose to talk about obstetrical care because I think that's exciting and we can make a lot of public health impact. And to point out why people are interested in obstetrical care, maternal, if for those of you who follow news, related to this, maternal mortality is a national crisis. So what is maternal mortality? A death of mothers due to pregnancy complication and within postpartum, within 12 or 18 months, depends on the definition. As you can see from the bars on the left-hand side, this was pulled out from National Center for Health Science Studies, statistics, and you can see that non-Hispanic Blacks are at much higher risk for maternal mortality. And on the right panel, you see a graph for the maternal mortality rate. Older women are at much higher risk. So this has actually made it, and unfortunately, US is among the worst in the developed or developing nations for maternal mortality. So it's of focus. And Vice President Harris had made it her primary goal, one of her focus points when she became Vice President, to make an impact. So if you do a search on White House and maternal mortality, you will see all that's ongoing on a regular basis. And the other thing, which is of more global crisis, which is, of course, US is part of it, is increasing C-section rates. The only thing I want you to look in this plot is the increasing trajectory, rising trajectory. C-section rates world over is increasing. These are rates from 90 to 2018, projected up to 2030. Ideal number should be between 10 to 12%. We are skirting on 32% in US. Some countries like India, China, and all are 44%. So, and why do we care about C-section? Because it's a major surgery. It comes with its own complications and poor care provided and leads to, incorrectly done, leads to maternal mortality. So American College of Obstetrics and Gynecology and World Health Organization brought out a lot of, they tend to look at emerging crises and bring out what the doctors and public health researchers should be focusing on. So the emphasis is a lot on decreasing unnecessary C-sections, while making sure that the maternal and neonatal morbidity does not go up. Neonatal is babies getting born right around that window. So, the clinical guidances are moving towards implementing guidelines which can be quantitatively supported. And that's where statisticians / data scientists play a role. And so I'm now going to switch gear and talk about what those things are. And I'm only going to, in not taking up the whole lecture, I'll just point out briefly where we have a lot of rooms for research and make an impact. A point that I did not mention, which I listed out, is there are 3.9 million babies born per year in US. So all the guidelines are for in any hospital, for them to deliver babies, they have to adapt to the guidelines that are brought out. So when you work on these things and make an impact, think about you're making an impact on 10,000 babies that are born per day. So if you're interested in doing research which impacts public health, this is the area. Now, why SLAM? This is how the labor progresses. There are 3 stages of labor. The first stage is where a woman dilates from 0 centimeter to 10 centimeter. It is measured in unit increment. Now, if you are interested purely in total duration, it is what is called length biased. You will definitely hear from Mei-Cheng. She's one of the experts in this area. Reason it leads to length bias is there is an unmeasured, nobody comes at 0 centimeter dilation. They are advanced by the time they come to the hospital, and nobody knows when it starts. And if you look at it centimeter by centimeter, it is a recurrent event data. And it can be at the end point is going to be a competing risk scenario. You already heard from Mei-Cheng all the names that I'm mentioning. Second stage of labor is when once she completes the first stage. Second stage is where the time is competing risk. And if you want to be very nuanced and look through it, it tracks how the fetus is coming down so that it can get out of the mother's birth canal. And that's measured from -3 to +3. It's a multi-stage data. This is so-called tracking data where you're moving through stages. And the third stage is once the baby comes out, the job is not done. She has to also expel placenta, which is subject to right censoring. Some women are unable to do, so there has to be medical intervention. Now, why do we need to know the structure? Because we have to model and typically try to understand the risks for various complications. There are two studies which are what are called the standards that are called the standard studies on labor progression that our institute has designed. What does it mean? These are the perfect women who are used to identify what is an ideal progression if there are no complications. These women are considered the supermodels of pregnancy. They have no flaws in them. And in 1960s, we did a study called CPP with 54,000 deliveries. And in 2000s, we did a study called Consortium on Safe Labor. So these two are what have been used to design the guidelines. And we have now, just to illustrate, nothing else. So the first stage of labor is an example of recurrent event with an unmeasured start time. So we are interested in understanding how fast or how slow a woman progresses. So putting a statistical hat, we want to understand the waiting time distribution or the gap time distribution for transition or recurrence of events. So posing that problem in that framework, we developed the distribution for gap time, not we, my postdoc did that, Ling Ma. And we accounted for all the nuanced things, and it appeared in JASA theory and methods. So there is room for, I wanted to point out these examples, depending on your interest. If you want to do foundational work, there are a lot of interesting questions here because of the complications underlying the data structure. And you can make a public health impact. So we built it. I'm just going to show you the results. These are the gap time for some of the transitions. Transition of dilating at 6 centimeters. This is 7, 8, 9, 10. When you look at, and then the two lines is, one is for the CPP, the older study, that's the solid, and dashed is for the CSL, the newer study. And you notice from the 9 and 10, this is a very important picture. It's really worth $1 million. It clearly shows women are traversing through 9 and 10 centimeters slower in modern times compared to the 1960s. So that is a place where unnecessary C-sections happen a lot. Doctors, if they use the 60 standards, think this woman is progressing very slowly. That means her labor is stalled. They go and intervene, and unnecessary surgery gets done. So we have raised, awareness on that. But when you look at the top, we only used 1,000 because we developed a very hard, computationally difficult semi-parametric approach over here. Expanding it to 200,000 plus deliveries requires computational development of a different level. And this paper that Mei-Cheng mentioned, I'm not going to talk in details, was something that came out of SLAM sessions, interacting with fellows. And that looked at the American College of, ACOG guidelines that came about. How long can a woman be allowed to push in the second stage without increasing risk for maternal morbidity? And they came with their guidance came out of expert consensus. That means a bunch of doctors sat and came up with the decision. but nobody had quantitatively assessed. So Eugene Lee built a model, developed this joint modeling framework, because the second stage is competing risk and morbidity is known yes or no at delivery. That's a current status data. She did a joint model, and I think she said, yes, the findings are reasonable, but you have to be careful. There are risk factors in certain scenarios that needs to be accounted for. Otherwise, the guidelines don't work for everybody, in other words. And this was the one that won ASA Outstanding Statistical Application Award. And the paper appeared in JRSSC. So the next one that I'm going to quickly talk about, this is my first foray into mentoring a MD student, but she's an MD and a data scientist was at Brown, and now she's moved on to Columbia. So her interest was in, because she's a clinical obstetrician by training. Okay, I know that women prolong in labor, but can we in real time identify who are the women at risk when they present themselves in the hospital for having a longer second stage? And we did a binary classification. We just said within guideline and out of guideline. And we did a lot of other things just to convey the point, because so the goal was to identify high-risk patients and identify important clinical and patient characteristics to help. So she worked with all of the 220,000 odd deliveries and identified 70 risk factors, the features, through, we had a panel of experts sitting and going through and identifying the features. And we built a binary classification. I'm only showing the binary classification, and ran through various models. And you can clearly see random forest was the best predictor among the lot. And not surprising, because the problem is this thing. And this is listing out the features in the order of importance. And I just want to point out parity. Parity means a woman who has delivered before is going to deliver much faster than the one who hasn't. And maternal age plays an important role. That's all I want you to take away. And this was done under interpretable machine learning approaches. I'm just presenting what are called the partial dependency plots. Top left is showing the impact of height. If it's a higher value, that means she's at a higher risk for longer labor. If it's a lower, lesser, it's a probability. And you can see for the height, after a point, it falls off. It's well known shorter women take longer time to deliver. Older women take longer time to deliver. That's the story of maternal age. And parity below. The women who have not delivered before, that's 0, are at a much higher chance of delivering, taking longer time. Now, I'll stop here and point out there are significant, I just showed, we used existing methods to analyze this, but there are significant challenges for a statistician when we looked at this problem. There is extreme imbalance in the data. That means even though we had 220,000 odd deliveries, only 2.8% had labor out of guidelines. That means had longer. So when you have such a lopsided data and with such a complex multi-stage modeling framework, there are no existing methods to the best of our knowledge on how do we do what are all the approaches that are provided for reducing the impact of imbalance in prediction are on much simpler data structure. So that's one thing. And even standard random forest is only built up to competing risk or what are called illness death models. Nothing more complicated than that. And added to that, we have informative examination time points, right? So the number of data points, number of examinations is definitely a factor that because you have more information on some and less on the other. How do we account for all these things in this type of random forest approaches? And I've listed out some other interests. I wanted to intentionally walk through multiple examples. If you're interested in foundational work, there's a lot of questions to be answered. If you're interested in methods to address scientific questions, we have some. And there are machine learning techniques that need to be built in this complicated situation. And the most emerging issue of interest is the impact of climate change on labor. We have hourly information on temperature change and pollution. How do you account for that in this complex scenario? So we are in a big data scenario and even bigger public, but we do have a much, much bigger public health impact. Every baby born in hospital in United States, we can have an impact. So if you like to work in public health, embrace SLAM and try to work on these topics. And this is where I'll stop. Thank you.
So, we have time for one quick question.
Sure.
If not, then, okay, so, yeah, we do have someone here like to ask questions.
Yeah, thank you for today's talk. This is really interesting. I'm wondering, do most maternal deaths happen from C-section or natural birth? You might have gotten into this at the beginning.
Sorry, I couldn't hear the question. Mei-Cheng, if you could repeat it.
Oh, yeah, so
I can.
Okay.
maybe you can come.
Come over.
Yeah, come over here. Yeah.
I was just wondering if most maternal deaths happen in C-section or natural birth.
Oh, okay. I didn't have the time, but C-section is a contributor. And so what happens is there are other issues of for maternal morbidities that tends to happen. But one thing is, think about it. C-section is a very complicated surgery, right? We kind of don't think of it like that. So there are a lot of issues, the complications happen, and they get clubbed under maternal mortality. So answer is yes. What percentage? Not 50%, but I would say around 30% of maternal mortalities can be accounted for.
Yeah, I guess that might be complicated to model because the women going to C-section might be like sicker, like in a worse condition, like harder.
Yes, definitely. I agree. So one has to tease apart these things.
That's great. Thank you, Raji.
Sure, you're welcome.
So now we turn to the third presenter.
Okay. Yeah. So hi everyone, I'm Chen. So let me, hey Raji.
Hi.
Oh, maybe the Raji needs to.
I stopped.
You already stopped?
Yes, you already stopped.
Yeah.
Maybe.
Go ahead.
Comes up. Yeah, no, I just saw it. Oh, yeah. See, share screen.
Okay, but where is the slide?
Your slides here.
I already double click. Oh, okay, now.
So I think it's this one, right? Huh? That's not. Maybe there's something. This one is yours.
Okay, slowly now.
Oh,
Okay.
okay. So I think that probably I should close it down. I should close this. Then share. This is yours. We can share. Okay.
Okay. So, yeah, thanks everyone. Can all see this?
Okay.
If I can make it larger.
Yeah, make it forceful.
Maybe just hit play.
Play? Here.
Okay. Okay. All right. Angela, can you see that?
Yes.
Oh, okay, thanks. So, yeah, first off, thanks everyone for coming over. So before I get started, actually, can I have some sense and maybe just for for the first sake for our discussion because this is informal. How many of you are new to Hopkins? Can you raise your hand? Oh, okay, quite good. Yeah, and how many of you are master students? Okay, again, majority. Okay, great. So, yeah, like Professor Wang mentioned, this is a survival and teaching and multivariate working group, and we're very, to some extent, informal discussions, meetings every Friday. So, my primary appointment is in school of medicine oncology, and that's where my most of my research happens, making both methodological work, but also applied statistics in particular cancer research. And I also have joint appointment with department where I advise students and teach occasionally. But and everyone, if you are interested in survival analysis, not yet, look for Daisy. She will. So here, my own research interest tied basically landing to survival analysis as well as clinical trial. I'll talk.
He's our clinical trial expert. So any question about clinical trial?
We also have experts here as well. Yeah,
Yan-Xun is also.
Yan-Xun is also.
From here, mine is only early phase, it's more early phase.
Okay.
And you are covering early phase and late
Yeah.
phase.
So,
Okay, good.
yeah, I guess we kind of have a different expertise, and you hopefully will see that sooner rather than later. So, one thing that actually my talk will be just several slides, and it will be very quick and non-technical at all. Before I get started, actually, how many of you heard of the term called evidence-based medicine? Okay, so not a whole lot. So actually, evidence-based medicine is a term that people have been chasing for, but not really practicing all the time. Let me put it this way. So as you may recall, physicians, when they treat patients, it's a trial and error process. And in many cases, they may not necessarily know how to treat patients. They just use the experience and treat it as they go. And sometimes it works, sometimes it doesn't. So concurrently with the clinical trials, the term and the practice of evidence of medicine also become populated, and it's more and more so, as you may imagine. So what it really means is that in order to guide the physician how to practice, meaning how to treat patients, how to diagnose patients, and how to eventually take care of patients, they'll require some level of some evidence. And this evidence typically comes from clinical trials, prospective clinical trials, and in particular, in most settings, if not all the settings, from large-scale randomized clinical trials, research clinical trials. So that's why clinical trials play kind of the cornerstone role in the evidence-based medicine, and especially in oncology, we typically that for every disease that where the physicians treat patients, it will require some kind of a high-level evidence in order to guide the oncologist to treat patients. So that's kind of the general background, and that's how many of my research comes from. I'll give you some examples of what my ongoing research looks like, very superficial. So one topic that I'm actively working on is about how to integrate historical and real-world data to facilitate clinical trial design. So the context here is that although it's maybe straightforward to design randomized phase 3 clinical trials, it may not necessarily always feasible, or sometimes it's just less desirable, in the sense that it always takes a long time to run a large phase 3 trial and randomization. Sometimes randomization may not work or less desirable. So in those settings, how to accelerate the whole process of generating evidence, okay, and get a result quicker. This desire also coupled with the increasing availability of historical data and real world data. So, because in the randomized clinical trials, the major idea is that you compare with standard of care or something that can be considered that you want to improve. So by definition, you would have the anticipation is that you may have better access to standard of care data or control data. So how to integrate that information actually becomes quite interesting. So I'm giving you some examples, some very hypothetical and just conceptual ideas that when you have multiple historical trials that's available that can serve as your control, then what may happen? Like for example, these trials may have heterogeneity across trials. Of course, in addition, I mean, just by definition, the patients are not necessarily same as you concurrently randomize patients. So all of this need to be carefully think through and to be planned ahead if you want to prospectively integrate this information in your trial design. When we say design, we mean that we want to prospectively plan that how many patients will be needed in order to generate the level of evidence we need eventually in several years. So there are huge investment involved when we plan a trial or design a trial. And then in the end of the day, we want to either able to answer the question that whether the new treatment works, or if it does not work, we at least know that okay, this particular option did not work, and it will lead to the next chapter of the research by providing a clear answer with the necessary uncertainty control, so that we are not just oh, it did not work, but why we don't know. So that's a thing. So in general, that's to some extent art of balancing between sometimes untestifiable assumptions and compromise between precision and accuracy. So just to stop there, just to introduce you the idea that there are actually, even just for the very classic randomized clinical trial design, there actually a great desire to utilize the new data source and the new data availability to accelerate clinical trial development, just in general speaking. This is the one general topic that I'm very interested. Another area that I'm also very interested in, have the opportunity to work with Professor Wang, is something I call disseminate and simplify the disease process. Professor Wang also mentioned that very briefly in her talk. But generally, I think this is something that have a huge impact in many clinical trials, generally speaking. Because if you think about that, unless we have a disease that's very, very acute, you always have a disease process where you have a series of we call it landmark events that categorize the disease severity. And if you think about that, it's not entirely clear to categorize the whole process. Which makes answering the question that whether the new treatment works or not complicated. If you look at each individual landmark event, you may individually, then you may actually come back with conflicting findings. It's possible. And this actually repeatedly presents challenges in practice. So how to reconcile that? I think this is just a very general topic. And also, across the whole disease process, which part may be more useful or more informative in terms of informing the subsequent, either the disease trajectory or the subsequent treatment? There are a lot of things that can be learned if you look at the whole process as a whole. So along this line, there's many work I have to say, and this is the whole thing called event history analysis if you're interested and have long history. So some related work that I have been working on, including that to look at the disease progression history in cancer, where we try to innovatively analyze the duration of different the duration of response, as well as how well the response looks like and how that may impact the subsequent patient survival. And another example would be, and another example is something that Professor Wang just mentioned, that for example, in the patient COVID clinical trials, where patients may have different disease severity as well as different outcome, then how to make sense with that. This is another very classic, very interesting problem that that requires very careful thinking to even just think about it, what question you can answer and make sense to ask. A third example actually comes also from clinical trials, where, as you may know, in clinical trials, there's never the clinical development never just a one shot. It's always in different stage, meaning that you have phase 1, phase 2, and phase 3. And what it means is that in phase 1, we first we want to understand that whether the new therapy, like for example, new drug, whether it's safe, and what kind of dose that should be given to patients that's both safe and potentially efficacious. And then in phase 2, we want to identify the signal, whether it's worthwhile to be further tested in the phase 3 part, so that we can definitively determine whether the new therapy should be used in the general population. So that's a stage testing. And in this process, there's a natural desire that to use something called the surrogate endpoint or intermediate endpoint to inform the long-term clinical benefit. In cancer, it will be overall survival or something like that. That will take time to observe and to mature, but also it takes time, but also that represents the true clinical benefit. But on the other end, you cannot really rely on these long-term endpoint for clinical development, because it just patients are waiting for new, more effective treatment. So in order to advance the clinical development faster, you need to have something that more can be assessed sooner. So surrogate endpoint or intermediate endpoint is naturally desired to look at. And there are different aspects to look at this problem. Again, this is a very broad and important topic. Here I just list some ideas that try to showcase that for a question like this, there are different perspectives, different angles to answer this question. On the top, that's the perspective of sometimes people call it a causal surrogate perspective, where at the individual level, we want to see that whether the effect that can be mediated by the surrogate endpoint. But also, I want to just give you an idea that there are also the so-called trial level surrogate, where you want to see that whether the treatment effect on the intermediate endpoint or the surrogate endpoint can meaningfully predict the long-term outcome. So, and these are actually different things, and that requires careful thinking as well as a different analysis method. So these are, so hopefully it makes sense that through these three examples in different contexts, I'll give you the idea that I think both my research, but probably also very relevant to all of us, is that when we think about these interesting problems, we want to understand how the data were collected or will be collected, understand why they are collected, and then understand the goal so that we can come up with the necessary statistical method, ask the right question before we even just think about the model. And then, my own experience, since the day one I enter Hopkins, is that the SLAM is the right place that if you are interested in answering all of this. So I'll stop here and thank you all for your attention.
Thank you so much. Question? Time for one quick question. Okay, no question. Probably we'll have the last presenter, Jessie.
Everyone, my name is Jessie. I'm a new assistant professor in the department, and thanks Mei-Cheng for inviting me to join this working group. And
By the way, I just want to say, Jessie's advisor, was a loyal member of this working group. And he actually gave multiple talks, at this working group.
I'm the granddaughter of this department. Cool. So today I'm going to talk about a few projects I have been working on back to Penn, and the thing I'm working on right now, and they are all related to real world data. First, a very brief introduction. I went to UC San Diego for my undergrad, majoring in applied mathematics. Then I moved to Philly, working with Chen on projects related to real world data, especially EHR data. And this August, I moved to Baltimore as an assistant professor in biostatistics. And in the past few years, a lot of projects are focused on real world data. And here, real world data means that we look at the patient's health information. They're collected from some routine clinical care. But these data are outside the typical research settings, like the clinical trials, as Chen just mentioned. And some examples under real world data include, for example, electronic health records data, claims and billing data, disease registers data, and the mobile devices data. And when we analyze the real world data, we can generate evidence. That's very related to how we use evidence-based solution to provide answers to all of the questions there. And when we analyze the real world data, we do have different aspects, different methods, especially based on my experience when I work on EHR data. I found it's a large database with longitudinal data, time to event data. So you do have a lot of experts that can deal with data. And in the past few years, my research interest mainly focused on clinical evidence generation and evidence synthesis, especially from 4 perspectives. First one is the evidence generation with data from distributed research networks. And this is also the topic I'm going to dive into today. And I'm also very interested in other topics, for example, the measurement error problem in EHR-based association study. And I like collaborative research with biomedical applications experts. And also, I'm a fan of software and R package development. So if you are interested in that, please feel free to reach out to me. Okay, and for the first section, the evidence generation with data from distributed research network. What is distributed research network? So here you can see in the past few years, there are a lot of databases have been developed. And the reason they are called distributed research network is that within each, okay. So these are different networks, and within one network, there will involve multiple hospitals, multiple institutions, or multiple sites to contribute their data together. But sometimes the challenge is that they will pass data usage agreement. Sometimes they can pull the data together. However, sometimes they cannot do that. For example, the Odyssey, the one on the lower part, is called the Observational Health Data Sciences in Informatics. It is an international community. So when we conduct multi-site analysis across different countries, it is usually impossible to share the patient level data. So this is a key motivation for us to develop the statistical method so that we don't allow to share any patient level data, but we can still achieve the task. So this is our motivation. So the major goal is to integrate the data together and provide some evidence-based solution to the questions. And for my PhD thesis, it mainly focused on hospital profiling this problem. So hospital profiling means that we would like to conduct a comparison between different healthcare providers' structure, process of care, or outcomes. And there are some efforts have been made. For example, this is the website called Medicare.gov, developed by CMS. And on this website, if you type into your zip code or your location, you are able to see a list of the hospital nearby. And when you dive into this website, you can see like they provide different stars to hospitals. And if you want to treat, for example, COVID-19, you would choose the best one with the higher, like most of the stars to visit. And when we dive into this website, we like to see what really gives this score system. And we found that they use different quality metrics. For example, the complications, the death rates in their EHR databases, and to rank different hospitals. So this is a very interesting topic for me. So in the past few years, we have developed a series of methods to deal with the hospital profiling problem, with the major goal is to provide the answer to the question, which is that which hospitals are providing better care for the patient. So for the first phase, we developed a method called the distributed hospital comparator. And here there are some key features of this comparator, which is first, this comparator is able to be finished within only 3 rounds of communication. This is about the communication cost when you deal with multi-site analysis. So you can think about when we collaborated with the Odyssey community, we have international collaborator. We cannot ask our data partner to see there generate some aggregated data thousands of times. So we want to make the communication rounds as minimal as possible. So that's how we want to make our method as minimal rounds of communication cost as possible. And the second thing is about a case mix situation. And here case mix means the heterogeneity between different hospital population. And third one is what I just introduced. We would like to require aggregated data only instead of population like the patient level information. Okay, so I'm not going to introduce too many technical details here, but here is the backbone of this hospital comparator. And in this comparator, there are 2 major modules. The first module is that we're going to fit a generalized linear mixed effect model in a distributed manner. So here, what we're going to share will be some aggregated data, some point estimate with their variance, and some point estimate in the GLMM model. And after we have this point estimate, we'll move to our second module, which is a counterfactual modeling idea, which is used to handle the population mix situation. Okay, so this method has already applied to the Odyssey community, and we recruited 12 sites in total across 3 different countries, which is the truly decentralized research network. Patient level data cannot be shared, so we only collect the aggregated data from our data partners across the whole world and to achieve this hospital ranking test. And during this procedure, we found, okay, 3 rounds of communication, that's still too much for the collaborators. It means that we need to wait for everyone to get back to us, and then we move to the next round. So based on this very practical challenge, we are thinking, are we able to push it to another limit? Which means, can we deploy a one-shot algorithm? And here, one-shot means only 1 round of communication is needed, and we can require the aggregated data from our data partners once. And the reason we want to deploy this such one-shot algorithm is that it can enable the real-time monitoring tasks. For example, in COVID-19, at different time points, you just run the program once, and then you can have the ranking, and you can see the temporal trend of different hospital rankings. And that comes to the phase 2. And recently we're working on this one-shot distributed hospital comparer. And the major goal is we combine module 1 and module 2, feeding GLMM and feeding the counterfactual modeling idea together as one module, and require only one time of aggregated data to be shared from our data part. Okay, and when we working on this one, by collaborating with our data partners, they asked a very important question: is that what about time to event data? Currently, we're only interested in the mortality of COVID-19, which is a very important outcome, but they're still thinking about, since we have the real world data from our EHR database, how about something related to time to event data? And recently, we are working on this because we found that time to event data really provides additional information other than an indicator of the event occurred, but also when that event will occur. For example, when we study the disease progression analysis, we can help the providers, the patients, and also the clinicians to do some long-term care planning. So that's our work. And recently, we're extend the distributed hospital comparer to accommodate to the time to event data. And other than the first category, I have been also working on other projects. For example, the first category, we have developed some algorithm to assess, quantify the racial disparity problem. And also for measurement error problem, we are very interested in what about we have a partial chart review outcome and also full algorithm derived phenotypes. How can we efficiently combine them together to identify the risk factors? And also for the collaborative research we have done before, we collaborated with the PeaceNet network, which have more than 11 children's hospitals across the whole nation. And the major question we would like to study is what is the vaccine effectiveness for children and adolescents? And also, as I mentioned, I'm a fan of software development. Back the time at Penn, we have developed a software called XMeta, which is also a website. On this website, after you upload the data that you want to analyze, you don't have to know anything about R programming. You just click the buttons on the interactive website, then you will have the meta-analysis result. And related to the distributed learning algorithm, we developed a PDA and PDA OTA. We want to provide the end-to-end solution for clinical evidence generation. And that's all I have. Thank you.
Any question for Jessie?
Yeah, thank you for the wonderful presentation, Jessie. Would you mind go to page 13? I have a question about how we can merge the rank you derive from two models and how you hypothesize them.
So here, the ranking was produced at the end of module 2. And in module 1, we only obtained the point estimate for the parameters in the GLMM model. And then we use that estimate to do the further analysis and get a rank. And here, the way we combine this together is to use the PQL model, the penalized quasi-likelihood method, and so that we can decompose the likelihood so that every hospital can contribute some aggregated data in the matrix and combine them together.
Thank you.
Thank you.
When you're doing this kind of work, do you run into issues around hospitals storing data in different ways? And
Yes.
having different systems? And
Yes.
like,
Yes.
how do you deal with that?
That's a really good question. So people are making efforts to standardize their data into, they call the common data model. And recently, across all of the networks that have been introduced here, they have created different versions or different types of common data model. So for example, when we work with Odyssey, they have a common data model called the OMOP common data model. So it means that all of the data partner from Odyssey, they have the same data structure, same dictionary, same column name, which really make us to apply this method very confidently. Yeah.
For some of the multi-center, cohort study, this is actually a very good question. Like imaging data, measurement are, obtained using different devices. Yeah. It's a big problem actually, in for real data analysis, how to integrate the data together from different sides of the center. Yeah. Yes. No perfect answer now. People are working on that.
Any other question?
Any question? Could have question for any speaker.
Hi, sorry, I'm on Zoom. I had a question for Jessie.
Sure, please.
I was just wondering, you mentioned that like a key question in determining which hospitals are providing better, the key question is determining which hospitals are providing better care to patients. And during this evaluation, were you considering factors such as hospitals' location or demographics of surrounding populations, just because of who's able to access it or the costs and distance?
Yes, that's a really good question. So in this distributed hospital comparer, when we fit this the GLMM model, we do account for the site level covariate. For example, the number of ICU within one hospital or the zip code, and also some hospital level related covariate in this model, so that we can account for the hospital level heterogeneity instead of like the thing we only included in the first step, which are some patient level covariate. Yeah. Does this answer your question?
Yes, thank you so much.